This is Spela Gasperlin, and I'm a DMP student at KU Medical Center. I'm going to be presenting 3 studies that look at the effect of mineralocorticoid receptor antagonists on all-cause mortality in heart failure with reduced ejection fraction. According to the CDC, approximately 5.7 million people in America have heart failure. About half of those individuals who develop heart failure die within 5 years of diagnosis, with disease management costing the United States an estimated $30.7 billion annually. In addition to the significant costs associated with heart failure disease management, like hospitalizations and medications, for example, heart failure is also associated with significant morbidity and mortality, with 1 in 9 deaths being attributed to heart failure in 2009. According to Berry, Koshman, and Pearson, 1 of every 5 men and women aged 40 years and older will develop heart failure in their lifetime, with that number continuing to rise. Currently, heart disease is the number 1 cause of death in the United States, with the number of deaths directly connected to heart failure quickly increasing. The American Heart Association recommends guideline-directed medical therapy for the patient with symptomatic heart failure with reduced ejection fraction, also referred to as systolic heart failure, as a combination of the following medications: an ACE inhibitor or angiotensin receptor blocker and/or a beta blocker. Conditionally, the addition of a loop diuretic, hydralazine nitrate combination drug, and/or aldosterone antagonist may be appropriate. The terms aldosterone antagonist and mineralocorticoid receptor antagonist, or MRA, are used interchangeably to indicate the use of the 2 recommended drugs in this category: spironolactone and eplerenone. While spironolactone is also in the class of potassium-sparing diuretics, its recommendation is for aldosterone blocking capabilities and not to be used as a therapeutic diuretic. MRA therapy was added to guideline-directed medical therapy in 2013, but experts still debate its efficacy and strive to understand characteristics of a population that will benefit most from this intervention. According to Yancey et al., MRAs have a cardioprotective property in the population with an ejection fraction, or EF, of less than or equal to 30%. Research is emerging in the efficacy and safety, as well as significant mortality benefit with the use of spironolactone and eplerenone for patients with heart failure. This first study by Pitt et al. Is an RCT that sought to determine the effectiveness of daily 25 milligrams spironolactone in the reduction of all-cause mortality in patients with heart failure, reduced ejection fraction on previously tolerated guideline-directed medical therapy. In this groundbreaking RAILS trial, results showed a 30% reduction in all-cause mortality, as well as a reduced risk of sudden cardiac death, as well as heart failure hospitalizations, with the use of spironolactone in patients with congestive heart failure. Patients were randomly assigned to receive either 25 milligrams of spironolactone once a day or a matching placebo. After 8 weeks of treatment, the dose could be increased to 50 milligrams once a day if the patient was showing signs or symptoms of progression of their heart failure. If hyperkalemia developed at any time, the dose could be decreased to 25 milligrams every other day. The outcome of interest was all-cause mortality in patients with heart failure reduced ejection fraction. The primary endpoint was death from any cause, and follow-up occurred every 4 weeks for the first 12 weeks, then every 3 months for up to 1 year, and every 6 months thereafter until the end of the study. A total of 1,663 patients from 195 facilities across 15 countries participated in this study. Participants already had heart failure with a reduced ejection fraction and were already tolerating guideline-directed medical therapy. 841 patients were in the placebo group, while 822 received the intervention of 25 milligrams spironolactone daily. Strengths of this study include the size of the sample. A double-blind, random assignment strategy was used. Periodic reviews were conducted by a safety committee who were blinded to treatment assignments and cause of death. The trial was discontinued early after a mean follow-up of 24 months because it was determined that spironolactone was efficacious. This could be viewed as a limitation as the length of the study could have continued. As you can see, this first article by Pitt et al. Was statistically significant in showing a 30% decrease in relative risk of death in the intervention group, which was those people receiving spironolactone 25 milligrams once a day. The second study includes some of the same authors as the first. However, this study sought to determine the impact on eplerenone 25 to 50 milligrams daily on all-cause mortality in patients with an EF less than or equal to 30% post-myocardial infarction on guideline-directed medical therapy. This study was also an RCT. Patients were randomized to either 25 milligrams a day eplerenone or a placebo for 4 weeks. The dose of eplerenone was then increased to 50 milligrams a day on week 4 if tolerated. Follow-up visits were scheduled at 1 and 4 weeks, 3 months, and every 3 months thereafter until the study ended. Patients were followed for up to 2.5 years, with a mean follow-up of 16 months. Time to all-cause mortality and time to first occurrence of cardiovascular mortality or cardiovascular hospitalization were the two primary study endpoints. There was a relative risk reduction of 21% on all-cause mortality in the intervention group. The relative risk of sudden cardiac death was reduced 33%. Heart failure mortality and heart failure hospitalization was reduced 25% with eplerenone compared with placebo. Within 30 days of randomization, eplerenone resulted in relative risk reductions of 43% for all-cause mortality, 29% for cardiovascular mortality and cardiovascular hospitalization, and 58% for sudden cardiac death. Once again, the study by Pitt et al. Found a relative risk reduction of 21% with eplerenone, which helps support the use of eplerenone for significant protection from all-cause mortality if initiated in the immediate post-myocardial infarction phase given a low ejection fraction. A total of 2,016 patients from a subgroup of aphesis patients with a baseline EF less than or equal to 30% post-myocardial infarction were evaluated. 1,048 patients received eplerenone and 1,058 received the placebo. Strengths of the study include the sample size as well as the double-blind placebo-controlled study design. Bias was controlled through randomization, and results were controlled via randomization and oversampling for attrition and death. Limitations of the study include the very specific population of patients with heart failure post-MI. The results, however, still fall under the umbrella of heart failure patients treated with MRA therapy as compared to a placebo and directly measure incidence of all-cause mortality, so the study was included in this analysis. This final study by Zinad et al. Evaluated the effectiveness of eplerenone 25 to 50 milligrams daily in heart failure with reduced ejection fraction patients on all-cause mortality. Once again, this was an RCT. Patients were randomly assigned to either eplerenone at a dose of 25 milligrams once daily that was increased after 4 weeks to 50 milligrams once daily, or a matching placebo in addition to recommended therapy. Investigators evaluated patients every 4 months with a median follow-up period of 21 months. The primary outcome of interest was a composite of death from cardiovascular causes or a first hospitalization for heart failure. Results showed that death from any cause was 19.8% in the intervention group compared to 27.4% in the placebo group. Geographically, the sample included subjects from 29 countries. 1,364 patients were randomly placed into the eplerenone group, and 1,373 were assigned to the placebo. Patients taking eplerenone with guideline-directed medical therapy experienced a reduced incidence of all-cause mortality. All-cause mortality occurred in 12.5% of patients in the eplerenone group and 15.5% of patients in the placebo group. Strengths of the study include the sample size as well as the double-blind placebo-controlled study design. Sample selection methods were blinded to reduce bias. The trial was stopped prematurely at 21 months due to pre-specified rules, which could be looked at as a limitation. In determining possible causation between the exposure and the outcome, it is useful to implement Henneken's criteria. In study number 1 by Pitt et al., there was a relative risk reduction of all-cause mortality by 30% in the spironolactone group. It is improbable that this risk reduction was due to chance because the 95% confidence interval was 0.60 to 0.82 and the p-value was less than 0.001. A risk ratio less than 1 suggests a reduced risk in the exposed group. The risk ratio in study number 1 was 0.70. In study number 2 by Pitt et al., there was a relative risk reduction of 21% in the eplerenone group. It is improbable that this risk reduction was due to chance because the 95% confidence interval did not include 1 and the p-value was 0.012. A risk ratio less than 1 suggests a reduced risk in the exposed group. The risk ratio in study number 2 was 0.79. Study number 3 by Zanad et al. Found a hazard ratio of 0.65. The hazard ratio is a comparison between the probability of events in a treatment group compared to the probability of events in a control group. It's used to see if patients receiving a treatment progress faster or slower than those not receiving treatment. With a hazard ratio of less than 1, survival was better in the group receiving the intervention versus the placebo. Death from any cause was 19.8% in the intervention group compared to 27.4% in the placebo group. It is improbable the results are due to chance because the 95% confidence interval was 0.62 to 0.93 with a p-value of 0.008. Study number 1 and number 3 required a p-value of less than 0.05 to determine statistical significance. Study number 2 required a p-value less than 0.04. Confounders were well controlled in all 3 studies, and all 3 studies were subject to bias as listed on the table. None of the 3 studies listed established temporality. All 3 studies were designed to establish a dose-response relationship. With the exception of transplantation, heart failure is currently an incurable disease. While the exact understanding of why MRA therapy leads to better outcomes for patients with heart failure are unknown, it is clear that the right combination of medical therapies may increase a patient's lifespan and quality of life in terms of symptom management. The introduction of MRAs to guideline-directed medical therapy may significantly reduce the risk of all-cause mortality in patients with heart failure. The results of this investigation conclude that the addition of MRA therapy to maximum tolerated guideline-directed medical therapy caused a clinically significant reduction in all-cause mortality in patients with heart failure reduced ejection fraction. Future research may investigate the optimal timing for initiation of treatment and the efficacy of MRAs dependent on cause of heart failure. Additionally, it is the recommendation of this speaker that future studies directly compare whether one medication is superior to the other. That is spironolactone more efficient than eplerenone in reducing all-cause mortality in patients with heart failure, reduced ejection fraction?